Good afternoon, everyone. My topic is local anesthetics and last, local anesthetic systemic toxicity. My name is Dr. Manish Patil. I am assistant professor at Government Medical College, Nagpur. Specific learning objectives are mechanism of action of local anesthetics, pharmacology and pharmacodynamics, pharmacokinetics, and toxicity of local anesthetics. Local anesthetics are drugs which upon topical application or local injection causes reversible loss of sensory perception, especially of pain, in a restricted area of body without loss of consciousness. Local anesthetics block the conduction of impulses in electrically excitable tissue. Not only sensory but also motor impulses are interrupted when a local anesthetic agent is applied to a mixed nerve, resulting in muscular paralysis and loss of autonomic control as well. In history, cocaine was first used by Karl Kohler, who was an Austrian ophthalmologist. Chemistry of local anesthetics. Clinically useful local anesthetics are weak bases with amphiphilic property and alkaline pK value. Most local anesthetics consist of three parts: tertiary amine, aromatic residue, and intermediate chain. Tertiary amines are hydrophilic, aromatic ring are lipophilic, and intermediate chain can be ester or amide. Based on this, these are classified into two groups: amide groups and ester groups. Amides are lignocaine, bupivacaine, prilocaine, propivacaine, and esters are cocaine, procaine, chlorprocaine, tetracaine, and benzocaine. Amide local anesthetics are all contain 2I and they are extensively bound to alpha-1 acid glycoprotein more than albumin. Binding decreases with reduction in pH, so hypoxia and acidosis can lead to toxicity of local anesthetic agent. They undergo hepatic metabolism and they are stable in solution. Compared to amide, esters are unstable, undergo hydrolysis by pseudocholinesterase, and the incidence of hypersensitivity is greater with esters than amide due to breakdown product PABA, para-amino benzoic acid. Local anesthetics can also be classified depending upon their duration of action. So short acting are procaine, chlorprocaine, intermediate acting are lignocaine, mepivacaine, prilocaine, and long duration of action with bupivacaine, ropivacaine, etidocaine, tetracaine, and dibucaine. As surface anesthetics, soluble are cocaine, lignocaine, tetracaine, and insoluble are benzocaine and butamine. Local anesthetics can be used in local infiltration, topical anesthesia, peripheral nerve block, just explained by Dr. Ranjit, and neuroaxial anesthesia, that is spinal anesthesia and epidural anesthesia. Lignocaine is antiarrhythmic agent and can be used in pain management as continuous infusion. Mechanism of action of local anesthetics. Local anesthetics act by blocking voltage-gated sodium channels. Non-ionized form crosses the lipid membrane of the cell, and inside the cell it gets converted into ionized form. Ionized form is active form which blocks the voltage-gated sodium channel from inside. This prevents further generation of action potential and by stabilizing the membrane. Local anesthetic preferentially block inactivated or open channels than closed channels. So they have greatest effect when nerve is rapidly firing. Pain and sensation, nerve fire at higher frequency than motor, and so they are blocked preferentially. This is called state dependent blockage. Even with close proximity of deposition, only 1 to 2% of local anesthetic penetrate into nerve. The degree of nerve blockage depends on local anesthetic concentration and volume. A fiber are blocked by lower concentration than C fiber, and we need sufficient volume which is needed to suppress the regeneration of nerve impulse over a critical length of nerve fiber. Too short exposure length allows impulse to skip over nodes that are blocked even by higher concentration of drug. In pharmacodynamics, potency potency correlates directly to lipid solubility and molecular weight. More the lipid soluble drug, more will be its potency. For example, bupivacaine. Bupivacaine is 7 times more lipid soluble than lignocaine and has more potency. Potency is increased by adding large alkyl group to a parent molecule. So, higher the molecular weight, higher will be the potency. Onset of action. Onset of action depends on lipid solubility and relative concentration of drug. Sorry for this busy slide. pKa is the pH at which the fraction of ionized and non-ionized drug is equal. Local anesthetics with a lower pKa will have a higher unionized fraction than those with higher pKa. This means that a greater proportion of administered drug dose will be available to cross the neuronal membrane, and faster will be the onset of action. At physiological pH 7.4, bupivacaine, which has pKa value 8.1, is only 15% unionized compared to lignocaine, whose pKa value is 7.9, which is closer to physiological pH, which is 25% unionized. More unionized form will be available for crossing the membrane, and therefore lignocaine is faster than bupivacaine. Addition of soda bicarb causes surrounding pH to rise. This will generate more non-ionized form, and more amount of drug goes into the cell, quicker will be the onset of action. In case of infection, surrounding pH in infected tissue and abscess is acidic. So local anesthetic will not work because most of the local anesthetic will be in ionized form. Duration of action mostly depends on protein binding. More protein bound the drug, longer will be the duration of action. Example is bupivacaine, which is 95% protein bound, has a longer duration of action than lignocaine, which is 65 to 70% protein bound. Addition of vasoconstrictor such as adrenaline also prolongs the duration of action by reducing washout of the drug into the systemic circulation. Addition of clonidine increases the duration of action. It has inhibitory effect on A and C fibers. In pharmacokinetics, absorption, mucous membrane provide minimal barrier and rapid absorption. On the other hand, skin requires higher concentration of lipid-soluble local anesthetic agent. Systemic absorption of injected local anesthetic. It depends on the blood flow, and blood flow depends on site of injection. Vessel-rich tissue results in higher concentration, systemic concentration. Obviously intravenous, and more blood supply is to intercostal than brachial plexus. So intercostal block predispose patient to toxicity more than brachial plexus. This is the sequence. Tracheal, then intercostal, then paracervical, then epidural, then brachial, then subcutaneous. Presence of vasoconstrictors such as adrenaline or phenylephrine causes vasoconstriction and decreases absorption of local anesthetic into the systemic circulation, limiting its toxicity and prolonging duration of action. In pregnancy, due to effect of progesterone, nerve fibers become sensitive to local anesthetic, and we require less amount of local anesthetic agent in pregnancy. If we mix two local anesthetic, we will get quicker onset of action and prolonged duration at the cost of toxicity. Distribution based on organ uptake is determined by tissue perfusion. In alpha phase, highly perfused organs such as brain, lung, liver, kidney, and heart are responsible for initial rapid uptake. In beta phase, less perfused tissue such as muscle and gut, there is slow distribution in muscle and gut. Protein binding. More protein binding, then more remains in the blood, and muscle is the largest reservoir of local anesthetic. Biotransformation and elimination. Esters metabolized by pseudocholinesterase. Ester hydrolysis is very rapid, and water-soluble metabolites are excreted through urine. And in amides are metabolized by microsomal P450 enzymes in liver. Decrease in liver function or blood flow to the liver predispose patient to a greater risk of systemic toxicity. Prilocaine is metabolized to orthotoluidine, which produces methemoglobinemia. Individual drugs. Lignocaine is amide. It has faster onset of action as pK value is 7.9, which is nearer to the physiological pH. 70% protein bound. It is medium duration of action. It has medium duration of action, and maximum dose can be given 3 mg per kg. But if we add adrenaline, we get more safer dose 7 mg per kg. Bupivacaine is also a amide, which is a racemic mixture of R and S enantiomer. Long duration of action due to high protein binding, that is 95%. It is extremely toxic to heart. Maximum dose is 2 mg per kg. We have levobupivacaine, which is S enantiomer of bupivacaine. Longer duration of action, and it is less cardiotoxic than bupivacaine. Its maximum dose is also 2 mg per kg. We have ropivacaine. It has long duration of action, more selective sensory neuronal blockage than motor blockage, and it is least toxic among bupivacaine and levobupivacaine. Maximum dose is 3.5 mg per kg. Prilocaine is amide. It has faster onset, medium duration of action. It is constituent of amla cream. It causes methemoglobinemia and less toxic than lignocaine. Used in Beer's block, and maximum dose is 6 mg per kg. Cocaine is ester, short duration of action. It causes profound vasoconstriction. It blocks neuronal reuptake 1 and stimulates CNS. Side effects are hypertension, hallucination, seizures, and coronary ischemia. Maximum dose is 3 mg per kg. In this chart, we can see the agents, techniques which are used, and concentration available in market, maximum dose, and typical duration of nerve block. Local anesthetic toxicity. Systemic circulation of local anesthetic agent affects CNS more than C waves. CNS symptoms are lightheadedness, tinnitus, circummolar paresthesia, tongue numbness, diplopia, blurred vision, altered mental status, visual hallucination, generalized tonic-clonic seizures, and loss of consciousness. In CVS, we get negative inotropic effects, prolongation of PR interval, and white QRS complex, ventricular arrhythmias, and asystole. In management, immediately we will stop the injection and call for help. We will give 100% oxygen and maintain the airway. We may need to induce anesthesia and intubate the trachea. After intubation, hyperventilation, it helps to avoid acidemia, which also increases the toxicity of local anesthetic and decreases cerebral blood flow, so less amount of drug will reach to brain. Control of seizure with small doses of benzodiazepine. In induction, we will use thiopental sodium and propofol. If there is ventricular arrhythmia, start CPR and start intralipid therapy. Intralipid therapy with injection 20% lipid emulsion intravascularly. Dose is 1.5 ml per kg over 1 minute. Then infusion 15 ml per kg per hour. After 5 minutes, reassess the patient. If there is no cardiovascular stability, then repeat the dose of 1.5 ml per kg. Maximum 3 bolus dose we can give, and also increase the infusion rate, double the rate, 30 ml per kg per hour. Continue until cardiovascular stability is restored or maximum lipid dose is reached, that is 12 ml per kg. Secondary action, take the blood plasma level amylase, transfer patient to ICU, check amylase and lipase daily for 2 days to rule out pancreatitis after lipid therapy. Explain the relatives and patient about the event. Risk factors for local anesthesia toxicity are large volume or high concentration of local anesthetic agent use, surgical infiltration, failure to aspirate during injection. If you don't aspirate, intravascular injection cannot be rolled out. Landmark technique, which is blind, there are more chances of intravascular injection. Drugs with narrow therapeutic index like bupivacaine and prilocaine are used. And patient factor, when there is decreased hepatic function as in cirrhosis of liver, decreased liver blood flow as in congestive cardiac failure. How to prevent this? Regional block area should be equipped to deal with cardiovascular collapse. Dose should be adjusted according to patient's age and weight. and gentle aspiration of syringe should precede every injection. Verbal contact with patient always be there. It has to be there while giving the drug. Test dose should be given in epidural, and use of ultrasound for regional block. A short note on EMLA. EMLA is 5% eutectic mixture of local anesthetics. It consists of a mixture of lignocaine 2.5% and prilocaine, which is also 2.5%. Depth of analgesia we get is 5 millimeter. Duration of action is around 2 hours. Amount of drug absorbed depends on application time, dermal blood flow, and the total blood dose administered. Typically 1 to 2 gram of cream is applied per 10 centimeter square area of skin. Dermal analgesia sufficient for insertion of IV cannula requires 1 hour under occlusal dressing. EMLA cream is contraindicated for use on mucous membrane, broken skin, and infants less than 1 month of age, and patients with a contraindication to either lignocaine or prilocaine. In summary, local anesthetic provide anesthesia and analgesia by blocking transmission of pain sensation along the nerve fiber without loss of consciousness. So, we can avoid general anesthesia. Most pharmacological preparations properties are decided by amide or ester intermediate link chain between aromatic and amine group. Local anesthesia potency depends on lipid solubility. Onset of action depends on relative availability of unionized fraction, and duration of action depends on protein binding. The site of injection is important, especially in terms of toxicity, as the rate of systemic vascular absorption of local anesthetic varies with site. With wide variety of local anesthesia use, measures should be taken to prevent local anesthesia toxicity and its dreadful effects. Local anesthesia giver should be aware of signs and symptoms of local anesthesia toxicity and its management. These are my references. Thank you.